Welcome everybody. I'm honored to be involved in the session, and as always, Seattle Science is doing just a fantastic job with it. The talks today have been really good. So I am going to share with you some of my insights into robotics and into MIS surgery. I've been at this for well over 30 years now, and multiple aspects of robotics as well as multiple aspects of MIS surgery, although today my practice is kind of refined to revision. 70% of what I do is revision surgery, unfortunately, and revision deformity surgery. So I'm going to show you some of the little tricks that I've been working on over the years. In the spirit of disclosures, I do have relationships with each one of these companies here. Some of them are robotics companies, as you can see. I was one of the inventors, patent holders, conceptual designers of the Mazor robot early on in 2000. That's when we started that project, although I'm no longer affiliated with that project. Yeah, the interesting thing is we are all sitting here talking about MIS surgery as if it's something that we dreamed up today, something that's sort of brand new. But in fact, the first recorded minimally invasive surgery was in the ancient Egypt transcripts from Ramses II. And this is a statue of Ramses II in the middle of the desert in Egypt, in Memphis. And if you look closely, you can see just inferior to the umbilicus, there's this scar that the sculptor put in there. And as history recorded, Ramses II had his gallbladder drained in a minimally invasive fashion just through a puncture wound. Now, that's a long route to the gallbladder from underneath there. So I kind of wonder exactly what went on. But minimally invasive surgery is not something new. This has been around for hundreds and thousands of years. In the 1800s, this is what an operating room looked like. Very different than what we do today. And here's what we were doing 15 and 20 years ago for a lot of our spine surgery stabilization. And by no stretch of the imagination is this good. We know that all the collateral tissue dissection damage causes harm. So we've learned, and what we've done is we've taken the tools that we have, we've recognized the anatomy, and we've been able to focus down and being able to target the pathology. So minimally invasive surgery is not one item. It's not one robot. It's not one technique. It's not just perk screws or single position laterals. It's a philosophy of targeting the pathology in the least invasive, most appropriate fashion. And right now, as spine surgeons, we're privileged. We have all these tools on the shelf right now. And what we need to do is figure out how to use them appropriately, how to take advantage of them for the various pathologies that we treat and the various patients that we treat, because we all know that every patient is a little bit different. So here's sort of the synopsis of targeting the intervention to the pathological tissue with little or no collateral tissue damage. And this was my learning over 30 years, essentially, where we went from fluoroscopic guided percutaneous techniques with biopsies and vertebral augmentations to laparoscopic endoscopic techniques, and then going to mini open type techniques. And now we've added all these different new tools. But we have to remember that spine surgery is about control. We don't want to ever be in this kind of position where we have lost complete control. You know that this is not going to end up good. And in spine surgery, we tend to measure with a micrometer, but then we pull out a chainsaw and make our cuts with chainsaws. So this is where robotics now has helped us. It's helped us become more precise and more efficient. And these are the minimally invasive spine procedures that we can now do: decompressions, discectomies, vertebral augmentations. But with respect to the robotics, We're now doing percutaneous fixation, be it pedicle screws, facet screws, cervical spine, thoracic spine, lumbar spine. We can do our fusions with our anterior, transforaminals, direct lateral, again, using the enabling technologies to get us where we need to be, minimizing the collateral tissue damage. Now, the single most important lesson that I've learned over the years is the value of preoperative planning, coming to the operating room prepared. If you were about to build a house, you would not let that contractor build the house unless you saw the plans, the bill of materials, and you had a budget. They've got to come prepared. Likewise, if you're going on a plane, are you going to get on that airplane if the pilot doesn't know how much fuel he has on board, what the payload is, how the weather is up ahead? You need to have the preoperative planning. And this is where we've been deficient. And now I think we're all starting to realize the value of this, and the new technologies that we have is allowing us to preoperatively plan appropriately. So one of the criteria, the parameters for this talk was supposed to be accuracy of robotics for MIS surgery. And I really don't want to spend much time with this because we all know it's accurate. There's dozens and dozens of papers showing that the accuracy rates of screw placement are well over 98%. And yeah, so we can get to 99%. Yeah, that's better than 98%, but we're still pretty good with robotics for MIS surgery in terms of accuracy. But again, just to emphasize, the robotics has allowed us to preoperatively plan better, to facilitate these MIS procedures, to reduce the X-ray exposure, and ultimately reduce revisions. So this was the second parameter for this talk of what are the risks of robotic MIS deformity surgery? And as I broke this down, I broke down into three things: fusion, obtaining correction, and maintaining your fixation. So these are the things, and as I mentioned earlier, 70% of my surgeries now are revision surgeries. And these are the three issues that I see most commonly: pseudoarthrosis, lack of correction, and terrible fixation that's completely fallen apart. So this is where I embarked on percutaneous facet screw or facet fusions using the robotics. And this is a case, this is a 68-year young male. And you can see here, multi-level degeneration, an L4-5 spondy, end-stage generation at 5-1. Here's his MRI scan. You can see what's going on. This is a dime a dozen. We see these patients every single day, and we want to do something in the least invasive fashion for him. So here's my preoperative plan, coming to the operating room prepared: percutaneous posterior instrumentation. But if you look here, you can see these areas where I am drilling out the facet joint in a percutaneous fashion and then stuffing the facet joints with bone graft to facilitate that posterior fusion. And here's what it would look like intraoperatively. I've got my screws in place. I've got the drill down through the facet joint. I've already got my cage in place for him. And then here's his 3-week picture. But here is his 1-year follow-up. And you can see how we've been able to fuse the facet joints on both sides in a percutaneous fashion, in a minimally invasive fashion. And I've got good anterior column, good restoration of lordosis, indirect decompression, all the things that we have talked about. So we've now analyzed 53 of these patients that I've operated on. Again, it's a typical cohort, age somewhere around 57, body mass index around 30-ish. The diagnoses: spondies, degenerative discs, scolies, post-laminectomy syndromes, adjacent segment issues, and metastatic tumors. But here you can see 55% of these people had prior lumbar surgery in this group. So again, a heavy revision group. And you can see here the levels that I operated on: 1-level fusions in 24, 2-level fusions in 19 as we're going through it. And here's the surgical data, and this is all MIS stuff that we all already know. very little blood loss in total. Some of these 18 were staged, 35 of them were done the same day as well. And then here were the complications that we had. We had one intraoperative minor surgery where one of the screws just didn't go in the right spot, so we had to revise that one. A screw loosening for a pseudoarthrosis later on, superior end plate compression fracture in one patient. And then we had a couple neurological type radiculopathy things that sort of resolved, and then some wound issues. Two were anterior, lateral, and one was posterior. But again, a very typical cohort of patients. The length of follow-up was well over a year in this group of patients. And then here is the combined pre-op VAS and ODI, which is, it's an interesting score, but it's really just more of a guide than anything. But these patients did do better. But the important thing is getting the fusion, doing that in a minimally invasive fashion, so that when we are doing something, we are achieving the same outcome. So the second thing was obtaining the corrections that we see. And this is work that we did with the utility of the preoperative planning for robotic guidance to gain the corrections that we wanted to get. And again, highlighting the importance of the preoperative planning and taking advantage of the robotics to obtain these corrections by placing the screws exactly where we want them to be placed. So this is a 16-year young male with an adolescent curve. Here again is my preoperative plan. And I typically do plan multiple levels above and below my intended fusion levels. If I run into a problem, I've already got it planned ahead of time. So I've got my plan A, my plan B, and my plan C. And here I am working through using the preoperative planning software to define the correction that I want. So I see where he lies now. I see where he is with the hardware in place. This is him in the coronal planes. We can see the extent of the curves. And then I start to rebuild his spine in a virtual environment. And I try to achieve a perfectly straight spine with all the parameters that we want. So I'm trying to take him down to 0 in his thoracic curve and lumbar curve. And then if we look on the left side, you can see the thoracic curve. I'm not quite happy with that. I want to give him a little more kyphosis. So I build in a little more kyphosis into it. And likewise, build in a little more lumbar lordosis into it to try to achieve the optimal correction. So here he is. This is what we started with. You can see what I planned and what I ended up with. And by placing the screws where they need to be placed, by contouring the rod in the way that we need to contour it, we're able to achieve those corrections. So we collected all the data prospectively. This has now been published, actually. This was the first group of 28 patients, of which 15 were scolies, 5 were kyphotic patients, a couple spondies, and adjacent segment deterioration patients. And here's the table with all the various parameters that we went through. And here you can see what we were able to achieve. So preoperatively, the coronal cobs measured somewhere between 27 and 30 degrees. We planned to get them as close as we can to 0. And postoperatively, I ended up with about 7 degrees of coronal angulation on the various cobs. In the sagittal plane, preoperatively, there were 20. Most of them, we want to increase the kyphotic angle, so it comes up to 26, and the post-op was about 25. So if you look at it, the accuracy of planning and the execution of robotics allowed me to get within 7 degrees of my coronal cob angles and within 10 degrees, say, of my sagittal cob angles. Now, you can say, well, that's not good enough yet. And yeah, it's not, but we're getting better. We're understanding more. Now I'm understanding more how I can achieve those corrections in a less invasive fashion. And one of the things that I'm still very, very concerned about, particularly with our deformity surgery, is the lack of ability to distract, to derotate, and to compress with the current instruments that we have. And there are things coming out, and I know we're going to be doing much better with it. So stay tuned. 2 years from now, hopefully I'll be able to show even better numbers than this with respect to our corrections and achieving those corrections. So our work showed that we can get within 7 degrees of the coronal plane and 10 degrees of the sagittal plane, but stay tuned because we are going to get a lot better. Now, this is what I feel really does matter. And for those of you who know me, you know that at Texas Back Institute, we have a gait lab. And I can't give a talk today without giving reference to the team in the gait lab and some of the work that we've been doing there, because it's just fascinating to me to see the numbers that we get. But it's really the patient objective functional outcome. And this is a great example that I like to show. A 56-year young female with this degenerative spine who presented to me with tremendous back pain, really a lot of difficulty with her day-to-day activities, radicular symptoms, as well as numbness in the right lower extremity. We also send at TBI, send our patients for pre-psych evaluations. And this was really, really important. If you look at her pre-psych evaluations, the patient believes that she cannot be helped. She broods and ruminates about her problems. She has an elevated sensitivity to pain and feelings of helplessness. But the psychologist felt that her psych issues were not so intense that surgery should be avoided, but that we should counsel her even more and get her through with these functional gains. So you can see what we started off with: a degenerative scoli, someone who's got some psych issues. Again, here's my preoperative plan, trying to get her going. This was a staged procedure, so I did anterior interbody fusions first. In between the anterior interbody fusions, I look at their alignment and then assess the extent of my posterior procedure for her. Here is the pre-op, the intra-op just before we did the screws. Here is intraoperatively. You can see we've got all the screws, we've got her correction in place. And then here's her pre-op and 1 year post-op x-rays. And really good alignment. I'm happy. The whole team's high-fiving themselves. We achieved our goals. But this is the patient's functional outcome measures, her patient-reported outcome measures. Here's her VAS. I got her from 7 to 6. Here's her ODI. You can see she's 58, 58 at 1 year. And she does not like me. She does not think I really helped her. But then we take her into the gait lab, and this is her pre-op analysis. And you can see her posture. You can see what she looks like there. Here's her 12 months. Right off the bat, you can see she's standing more balanced. She's walking better. But here we've got all her numbers. So you can see her cadence is much improved. You can see her stride time is much improved. Her walking speed is much improved. You can see her stride length and single support time. Every parameter has been improved. But one of the more important parameters is her overall balance. And you can see how we measure balance on a force plate with this cone, and the center of gravity, the red line that you see down here, is the center of gravity wobbling back and forth. And you can see how at 1 year post-op, she is now balanced again. So I show her these results, and all of a sudden her attitude changes. She now sees visually that she is functioning better, and this ties into her psych history and everything that's going on. So she's done really, really well. But here is how we were able to take advantage of the minimally invasive tools that we have, the robotics that we have, and using the gait analysis as well as the psych eval to optimize the patient's outcome. So please remember that robotics and navigation are not going to make a bad surgeon good. What it does is they will make a good surgeon more efficient and more precise. And with that, I'd like to thank you all and would be happy to address any of the questions.
Izzy, thanks. That was a wonderful talk on sort of the evolution of robotics from your standpoint. It's interesting, this is maybe a bit of an aside, but, proms now, pros are considered really the gold standard, and there's so many limitations. If you measure say an ODI on a patient and they're having a bad day, I would argue that they would answer poorly compared to maybe the day before when they, were happy for one reason or another. And it's a major limitation on it, on pros, but yeah, right now that's a standard. And I think you showed very clearly, on your gait analysis testing that objectively, by objective measures, patient's a lot better. And, the subjective component of it from the patient's perspective is a real thing. And so I don't know, what can be done for the future. Like people are looking at not your gait lab's great, but it's, I think a little bit challenging to generalize that to say my practice. So people are looking at measuring steps, for example, using your smartphone. I mean, do you think that's a viable alternative or what are your thoughts?
So you bring up a gait point. Yeah, not everybody can have a gait lab. And quite frankly, our gait lab was established 8 years ago, and it's already primitive. It's not even state-of-the-art anymore. And state-of-the-art today are the IMUs, the inertial modular units that we have that are in your cell phones that we can strap to patients and actually measure it. I have no doubt that the patient-reported outcome measures have misguided us over the years. We've relied too heavily on them. And if you sit in my waiting room for 15 minutes, you'll see we give all our patients a tablet, and grandma looks at the tablet, can't figure out how to enter her ODI, so she hands it to her granddaughter, and her granddaughter then spends the next 15 minutes while they're waiting to see me figuring out how they can surf the internet on the TBI tablet. And we have this documented because we can see what they're doing on it. It's very interesting. So patient-reported outcome measures are not the answer. Functional outcome measures are the answer. And IMUs are the next step where we're going to be able to do that. And there's different devices you can put in your shoes, you can put on your wrist, you can strap with little tapes onto your shoulder and at the cervicothoracic junction. And we're getting tremendous information that's state-of-the-art, more than what I showed you in this talk.
Great. Thank you very much, Izzy. Any questions? Yeah, Timur has a question for you.
Dr. Lieberman, thank you so much for sharing that amazing data. Question, you and other presenters today have discussed the convenience of using that preoperative planning software that comes with the robotic system and showing amazing cases how your preoperative plan matches your outcome. In the cases where it hadn't really helped you or you've had some issues and you couldn't achieve what you've planned for, what are the usual problems that you face?
So there's a whole list of those things. The biggest issue is obtaining the registration in someone who's osteoporotic and obese, or someone who has curves that are ranging over 80 to 90 degrees. That's where I'm finding a lot of problems. And as a surgeon, you always have to have your plan A and your plan B and plan C. You always have to have your bailout. So there's a bailout. If you can't get the registration, you can't get things in the right place. The second big issue is the revisions that I'm doing. Very often the spines have large wallowed out pedicle screw tracts, and I'm trying to find creative ways to drill across a pedicle screw tract. And as the drill is advancing, it deviates or skives off some of the cortical bone in the pedicle screw tract itself. So those are the other problems. And again, at that point, you just have to be creative in how to figure out how to do it. Occasionally, again, dealing with the osteoporotic bones, the problems that I've had has been when I'm going for my correction, I've got the screws placed well enough, but I'm putting too much force on it and I'm pulling out the screws. So I have become a very, very liberal cement augmenter of screws. And I'll augment the screws at the upper instrumented vertebrae. I'll augment the screws at the apex of the curve. And less commonly, I'm augmenting the screws in S1 or in the ilium because I'm now using a lot more S1 alar iliac and S2 alar iliac screws. I'm stacking screws to achieve my foundation. So those are the issues, and those are just some of the tricks that I've evolved to try to avoid those big issues.
Right. Okay, thanks, Izzy. Appreciate your
Awesome.
presentation.
Enjoy the day, everybody. Have fun with the rest of the talks.
Great, thanks. So.